Hi, everyone, and welcome to the final installment of Critical Care Echocardiography. Again, my name is Harrison Steins. I'm a fourth-year medical student right now applying emergency medicine, and I have a great interest in ultrasound, which I hope has come through over the past couple of videos. I hope that what you've taken from this is, one, a increased love for ultrasound, just like I have, as well as increased tools to put in your pocket, whether you're working in a hospital, in the ER, in the ICU, or in a far forward conflict setting, disaster setting, or resource-limited austere setting. I think that a lot of these tools that we can have in our pocket with portable ultrasound can bolster our clinical acumen, the decisions that we make about patients in clinical settings where we don't necessarily have access, time, or the ability to get further testing or additional imaging. So say you're out in a combat or deployed setting and all you have is your portable ultrasound that you put in your pocket. I hope that this lecture and this course series has given you some tools that, one, you're able to figure out how to find the views that we've talked about. Two, you're able to understand how to calculate some of the pieces that we've wanted to find, both with an ultrasound that can do it and then on your own using some of the pocket tools from some of the online resources and tables that I've supplied with you. And then finally, how you can use portable ultrasound and critical care echocardiography to influence decisions that you're making, whether it's if you need to transport someone, whether it's if you are going to add thrombolytics or anticoagulation to someone, or whether you need to diurese a patient or do something like a pericardiocentesis. Obviously, this is not medical advice or licensing for what you can go do, but I'm excited to wrap up this course series, and please message me with anything that you think might be helpful, both either to me or critiques or comments or anything like that. So wrapping up, we have the subxiphoid, IVC, and suprasternal views. So all of these are pretty vital in trauma and cardiac arrest. So the subxiphoid view especially is vital in trauma and cardiac arrest, especially during compressions or when your peristernal long axis view is unobtainable, whether it be due to body habitus or access around the team you're working with. So the subxiphoid view can facilitate rapid detection of something like a pericardial effusion and aid in estimating right atrial pressure and fluid responsiveness. Though they must be interpreted in the clinical context, just as everything that we've kind of talked about. So moving on to our suprasternal notch view, that's key to assess the aortic arch, although it's pretty often underused because in a resource-rich setting, we have something like CT where we can take our patients to that can truly visualize the entire ascending and descending aorta. But with a portable ultrasound, you can use a suprasternal view to visualize and assess the aortic arch for dissection or coarctation. And these are key in unexplained hypertension or chest pain without access to cross-sectional imaging. And then our IVC can help us guide volume resuscitation as well as get an understanding of right heart filling pressures. So this must be used contextually with ventilation status and understandings of RV compliance. But each of these, the subxiphoid, IVC, and suprasternal views, augment our overall assessment of the heart with critical care echocardiography and kind of round out our exam. So thanks for being here. Again, subxiphoid view, for those of you that have done the FAST view, this is awesome and included in that. I do like the peristernal long axis view. I use it in conjunction with subxiphoid view, but especially on larger patients, I think that I can get a quicker and better visualization of the heart and fluid surrounding the pericardium or within the pericardium. Again, just like in the FAST, this is mainly used for diagnosing pericardial effusions. You can detect chamber defects with this, ASD, VSD, congenital heart defects, things like that as well. Again, that'd be with color Doppler. Moving on to inferior vena cava. So if you've done the Rush exam, this is in your high map, your heart, IVC. This would be your second step. So you evaluate for central venous pressure and fluid tolerance. So in a critical care situation, if you didn't want to bolus someone with a small amount of fluid to see if they were fluid responsive or not, or tilt them back into Trendelenburg or reverse Trendelenburg, you could assess for IVC collapsibility. So we're going to talk a little bit about the sniff test and then how this differs for spontaneously versus ventilated patients. So from the subxiphoid view, with the patient still in the supine position, you can bend their knees if you want to bring fluid back into the thoracic cavity. You want to keep the right atrium in view. So you locate the inferior vena cava with the liver on the center of the screen. So here's liver. And then you need to know that it's your IVC because you see it dumping into your right atrium here. So once the IVC is centered, you can rotate your transducer to bring your indicator toward the feet. And then you get a longitudinal view of the IVC entering into that right atrium. And I see a lot of people starting to learn about IVC and looking at the aorta. With such big vessels, you can't necessarily rely on like the compressibility. You also don't know if your image is getting both of these or if you just lost the IVC and you're replacing that in your head with the aorta. So I kind of rely on dumping into the right atrium for the inferior vena cava identification. So as we start to calculate distensibility index and collapsibility index, kind of same thing, like how far the IVC can open up or collapse down based on the amount of fluid that is in our patient. We have to look at spontaneously breathing versus ventilated patients. Obviously, if you're not wanting to do your small fluid bolus and you just want a quick bedside thing, this is a great tool. So for a spontaneously breathing patient, you can have them take in a deep breath or sniff in, and then you're going to be measuring two things: the maximum IVC diameter, which will be seen during expiration, and then the minimum IVC diameter, which will be seen during inspiration for these patients. And that's due to thoracic pressures, right? Increased thoracic pressure collapses down your inferior vena cava, and decreased thoracic pressure, intrathoracic pressure, when you breathe out, increases the size. For ventilated patients, the positive pressure from the ventilator will have the opposite effect on the IVC compared to spontaneously breathing patients. So the maximum IVC diameter will be seen during inspiration, and the minimum IVC diameter will be seen during expiration. So once you've taken your calipers and you're measuring, I like to measure right as the IVC is dumping into the the atrium, but not actually at the atrium. You put these measurements into these calculations, which I've taken from an app called Resus -US, like resuscitation ultrasound, which is an awesome tool that I use all the time still, and I used a lot when I was first learning some of these exams. So suprasternal view, this is visualizing the ascending aorta, aortic arch, and proximal parts of the descending aorta. Great to see, thinking about like dissections, aneurysms, things like that. That is kind of the end of this presentation. I hope that you enjoyed it. It was a lot of fun to make, and I think I got to learn a ton about ultrasound. If you have any questions, always feel free to shoot me an email. If you just want to talk about ultrasound in medical school, and kind of more places to go from here, I am definitely open to it. If you have any critiques, I would welcome all of these. Again, my disclaimer is that I'm a fourth-year medical student now. Came up with this just because I really wanted to. I'm a predoctoral clinical ultrasound scholar, but I think that came about mostly because me and a couple of my colleagues just love ultrasound and love learning it, hopefully at advanced levels while we're still in medical school. So I hope you enjoyed. Obviously, it's a long lecture and you can kind of bounce around. If you have any questions or want any of the slides or anything, feel free to email me. I think that'd be great. Here's some of my resources. They're all awesome. Shout out to POCUS 101 and a couple of the cardiovascular societies and the POCUS Atlas and Resus.US. They're awesome apps, and thank you.